Okay, good evening, everyone. This is Alejandra. I'd like to thank you, first of all, for being with us today. And we want to apologize for a bit of a delay. This is only a technical problem. In the meantime, I want to introduce ourselves. We are the Emergency Medicine Club, and we will be showing today a very amazing uh, conference with Dr. Gupta, who will be talking about the trauma and COVID.
Can you hear
She
me,
is,
everybody?
yes, and she's here with us now. We can hear you.
I'm very sorry for all the delay that you all had to face. I am Dr. Geetanjali and I am based in India. And today I have been given a job to teach something to you, something about trauma. Can you see the screen? Hello?
We don't see the screen yet. No.
Yeah, we
Okay,
don't
one
see
minute.
screen.
1 minute. Let me go back.
Alejandra, you'll have to stop sharing your screen.
टीम्स को टीम्स ये वाला और खोलना टीम्स इधर का स्क्रीन दिखाओ इधर था ना स्क्रीन शेयर वाला नहीं
Where can I share the screen with you? कहाँ कहाँ पे जाऊँ?
There'll be a upwards arrow button right beside the microphone button. So when you press that, you can then import one of your presentations and.
Okay. 1 minute. Can you see the screen now?
No, we can't.
Not yet.
Okay.
देख रहे तूने गलत किया ना वहां से
कहाँ से?
Yes, we can see now. Your microphone is off, doctor.
Can you hear me now?
Yeah, we
Yeah,
can
hear
hear you.
you.
We can see the presentation.
Okay. I hope now we're about to. You can see the entire screen?
Yes, we can.
Okay. So today we talk about trauma, and if we get a trauma, how to proceed. Uh, trauma. I'll just give a background. This ATLS is the Advanced Trauma Life Support System, and we doctors from the American College of Surgeons developed it in 1979, and the UK accepted it in 1989. Primarily, our focus is to, the ATLS focuses on the rapid assessment and resuscitation, and that is called the golden hour, where we don't waste our time and we try to save lives. So historically we go by the tri-modal death distribution. So this is like immediate, within minutes, we lose lives at the scene of the death, or probably as soon as they reach the hospital, or within minutes. And further, we lose lesser lives when in the hospital. And this is the delayed phase when there is organ death and systemic failure. This is called the trimodal distribution of death as far as trauma goes. And if you see the causes of deaths due to trauma, the mortality is primarily due to hemorrhage and CNS injury. The central nervous system injury is supposed to be the most fatal of the lot, and 60% die within the first 4 hours, and 84% die within the first 12 hours. And further, and hemorrhage is one of the most primary concerns of the entire issue. After 10 years or so, there was another paper which said that there is a new bimodal trauma death distribution, wherein we started applying the ATLS and we started losing lesser lives when it came to the time after the immediate phase. So after the immediate phase, we started losing lesser lives because we had started applying the ATLS protocols. So I'm just going to give you an overview here. We prepare our trauma center as soon as we hear of a trauma coming in. Then we triage the patients according to the severity of their injuries. And as soon as the patient comes in to the trauma center or the ER, we do a primary survey, and ABCDE is the when you are in the ER, ABCDE is the sentence which you hear. It's not just a compilation of alphabets, it's the protocol that you have to follow. Further resuscitation, then we have some primary survey and secondary survey. We'll get into the details, but this is the stages of initial assessment. So in the pre-hospital phase, it's that phase where at the scene. So first of all, somebody, the frontline workers or the providers, first providers notify the hospital, and the providers manage patient on ATLS principles. We minimize the scene time and gather as much as information as possible from all the people around at the scene. As I mentioned, triage, it's sorting of the patients according to ABCs and available resources. And triage is primarily the responsibility of the pre-hospital personnel, not the doctors actually. So the basic fundamental is that the patients, the number of patients, the injuries of the patients should not exceed the ability of the facility which they are being shifted to. And in case when we have mass casualties, the principle is to treat the patient who has the greatest chance of survival first, and in the least amount of time, with the least amount of equipment and the least amount of personnel possible. So however it is, however brutal it may sound, but the person who has the most chance of survival gets the treatment first. So in the hospital phase, what happens is we brief the trauma team. As soon as we hear that there is a trauma coming in, we activate the team. We tell this person is going to be part of it, and we have a checklist. We prepare the equipment. We load the doses according to what information we have, so that we don't waste time after the patient is in. Then we make sure that all the personnel in the trauma team are wearing PPEs, and this is the time of such a contagion as PPE, as COVID. We have to have a proper personal protective equipment. So now I'm going to just tell you something. Trauma, uh, when it comes in, I'm just going to put my point. Okay, trauma, when it comes in, it could be either blunt trauma or it could be penetrating trauma. And when you have a patient coming in, we don't think, oh, it's a penetrating trauma, it's a blunt trauma. We manage them all the same. The principles will remain the same. So we take it into generalia, where we say primary survey. Primary survey is the first thing that you do, and it consists of A, B, C, D, E. I'll just elaborate after this slide what happens in A, B, C, D, E. You identify the injuries and you initiate the resuscitation. For instance, if you see this bleeding happening, you have to control the bleeding. That is, you initiate the resuscitation and you identify where all the patient has gotten hurt, and then you act. And then you activate the secondary survey, and the secondary survey includes a detailed head to toe examination. So A is the airway. Airway takes priority over everything else, and we'll talk about it as soon as we just finish a little basic fundamentals. If you see a person whose airway is obstructed by blood, vomit, or saliva blocking the airway, you first try to, it may be a foreign body also which is obstructing it. You first clear the airway because you don't want hypoxia to happen. In case you can't clear the airway by suction, you try to intubate the patient, or you could do an external tracheostomy to save the airway. So B is breathing. So first of all, we'd like you to inspect, auscultate, and palpate to see whether the patient is breathing or not. Breathing would include assessment a little further. So in case you see there is decreased breath sounds on auscultation, percussion, or palpation, in case you see there is some crackles, that would mean some subcutaneous emphysema, broken ribs, or in case you feel there's a tracheal deviation, it would mean one, pneumothorax. Pneumothorax is air inside the thoracic cavity, pushing, compressing one of the lungs, pushing the mediastinum to the opposite side. And pneumothorax could be open or closed. Closed is more lethal, and it is called tension pneumothorax. Secondly, it could be hemothorax when there's bleeding inside the pleural cavity. Again, compressing the lung, there will be decreased breath sounds over here. And the other lung, you will have to make sure even if that is injured or not. There could be a lung contusion. There could be broken ribs, and you have to look for flail segments. Do you know what are flail segments? Okay. Am I audible? Am I visible?
Yes.
Yes, we
Okay.
can hear you.
Yes,
Yes.
doctor.
Okay. You can stop me wherever you want to. So, flail segments are broken rib segments which are independently moving, like they're broken in one place and the second place. What happens is now this segment is going to move irrespective of the breathing, inspiration or expiration. Is it clear what I'm saying?
Yes.
Okay. Or it could be a cardiac tamponade which has happened. That is blood in the pericardial cavity. Now this blood is not going to let the heart pump blood outside. So even this has to be drained. Third is C, circulation. Circulation is you assess hemorrhage, whether it has occurred any place. How do you assess it? You see whether there is tachycardia or if there is any reduced blood pressure or increase in blood pressure. A Cushing's reflex could be happening somewhere. And as soon as you get to know this, hemorrhage is one of the causes of primary deaths in trauma. Bleeding could have occurred from the chest, abdomen, pelvis, or fractured long bones. These four are by far the commonest causes of hemorrhage in case of trauma. So what you do is you start two IV lines, huge IV lines, which will push in blood probably from one side or IV fluids from the second line. Third, next we come to disability, D. Disability is assessed worldwide on the Glasgow Coma Scale. For instance, if the doctor can ask the patient, "Can you hear me?" You are going to evaluate four things: eye-opening, verbal response, and motor response through this question. And and in case you get an answer from the patient, it would mean that he speaks clearly, that means his airway is maintained. B, that he generates air movement from speech. C, that he has good cerebral perfusion, that means his circulation is not bad. And D, that he has a clear sensorium. So within seconds, you can assess a basic primary survey of the patient. Now, E, exposure. So what you do normally is that you expose the entire body and you look for injuries. You remove all clothing, but you also make sure that the hypothermia doesn't occur, because hypothermia is also lethal to the trauma patient. You log roll the patient, you look for the spinal injuries and the back and the hips, and this completes our primary survey. And in case at any point in the primary survey you feel that you've made a mistake or you have to stop, you go back to the step one and then you do it again. You do not come to the secondary survey till you have completed the primary survey. The secondary survey includes head to toe examination of the entire body, plus, that is, these are adjuncts to the secondary survey. You do a chest x-ray, you do a pelvis x-ray, and you do a fast sonographic examination. We'll talk about this later. I'm primarily a radiologist and these are my fortes. So I like to talk about these things, but when the basics are there, we talk about the basics first. So all we want to do is prevent the triad of death after trauma, which is due to blood loss and coagulopathy, acidosis, and hypothermia. This is the classic triad of deaths that we want to prevent. So preparation would include handover from the ambulance, then you perform a primary survey, you obtain all information from all the parents, caregivers, wherever possible, and you ensure that a dedicated member of the staff is available to provide support to the parents and caregivers. Primary survey with resuscitation, I said. So it has to go hand in hand. You don't think that you're doing one thing and you can't do the other. You have to be multitasking here. So during the primary survey, you ensure that life-threatening conditions are identified and management is instituted simultaneously. Primary survey with simultaneous resuscitation, airway maintenance with restrict. Now I'm going to include certain things over here which are very important. When you look for the airway, you can't be maneuvering the cervical spine and neck as you like. You have to have restriction of the cervical spine motion, so that you don't injure the cervical spine in case there is a fracture of the vertebra, or in case there is a dislocation or subluxation. So breathing and ventilation we talked about circulation with hemorrhage control, then we talked about disability and the assessment of the neurological status, and we talked about exposure. So airway maintenance with restriction of C-spine motion. And why is it first in line? So airway is always first in line because if you lose oxygen, hypoxia occurs, and it causes inadequate perfusion and end organ damage. Airway assessment is very important, and we assess it by vital signs such as respiratory rate and oxygen saturation, the mental status, whether the patient is agitated or drowsy or comatose, or if you feel the patency of the airway is not adequate. So airway maintenance with restriction of cervical spine, as I said, you need to have a jaw thrust and you lift the chin, and the motion should be from down to up. Okay, and you make sure you stabilize the cervical spine with a collar, and you just listen whether there's any stridor, do suction. The chin lift or jaw thrust has to be done in a manner very gently, not very robustly. And in case you can't maintain an airway, you can use a tube or you could use a bag valve mask. So airway maintenance, this is the advanced. You can use a laryngeal mask or endotracheal tube or nasotracheal tube. In case there is injury to the base of the skull, then we don't go through the nose, we go through the mouth so that we don't injure the base of the skull. And in case we can't do any of the above, we try to do a tracheostomy or a needle cricothyroidotomy, or it's called a cricothyroidotomy. So in any traumatic patient, we would assume that the cervical spine injury has happened until proven otherwise, because it is a very prone part of the spine that is injured, like with multisystemic trauma. If you have altered level of consciousness and if there is blunt injury above the clavicle. Some tips to this: patients who are not, speaking normally generally do not have a need for airway management. If their voice is weak or hoarse, that is a subtle indication that there might be some tracheal injury or a laryngeal injury. And in case there is stridor or noisy respirations, then you can think that there is an obstructed respiratory pattern. We go to the next thing, breathing and ventilation. So you have to make sure that there is adequate gas exchange to maximize oxygenation and carbon dioxide elimination. So you expose the chest, and it's a 7-step approach. You check all the wounds, the veins, the trachea. You feel and you look, and then you percuss and listen to the lungs and the heart. So we want to rule out any tracheobronchial injury, a tension pneumothorax, or open pneumothorax. See, this is a pneumothorax. This is the collapsed lung, and this is air outside the lung. So that means it is leaking from somewhere. Air should be in the lung and not outside the lung. Okay? And it could be an open pneumothorax or it could be a closed pneumothorax. A massive hemothorax, that means blood is there in the pleural cavity compressing the lung. In that case, we put a chest tube in and we make sure that the blood comes out, or there's cardiac tamponade. And in case there is any of the hemorrhage going on, you will have a circulatory arrest. So we want to control the hemorrhage and shock. There are types of shock in trauma. It could be hemorrhagic, obstructive, neurogenic, or septic. So circulation with hemorrhage control, we go further and we try to identify the source of the bleeding. So I told you we do a chest x-ray, we do a pelvis x-ray, we do x-rays of the pelvis including the hip, and we, for the abdomen, we do a fast examination. So we maintain IV access so that at least we are pushing in as much as fluid as is being lost. We run a blood work, and we push in TXA, that is transaminic acid. It causes clotting and reduction of hemorrhage, and we activate all blood and blood products to be ordered. We do all the grouping at the site so that we don't do a mishap while giving blood or IV fluids. And then we try to stop the bleeding at the site, apply direct pressure, pat the area, or apply a tourniquet, or we, in case there is a fracture, we try to splint it. Again, this is the classic triad of death that we want to prevent. Disability. The principles of managing disability is to aim is to prevention of further injury and identification of neurologic injury. So precise diagnosis is not necessary at the time, but in case you feel that there is a decreased level of consciousness, a head injury is suspected, and in case of any trauma, you do a head CT. And you maintain oxygen levels so that cerebral perfusion is not compromised at any level. Exposure is you remove all clothing, you log roll the patient, and you avoid hypothermia by giving blankets. These are adjuncts to the primary survey. I've spoken in between slides that you need to see the oxygen saturation by a pulse oximeter. You need to take account of the circulation by a EKG. This is a monitor showing all the pulse, the oxygen level. This is the oxygen level, this is the pulse probably, this is the blood pressure. And then while doing everything like this, you see whether the patient is has passed urine, because with the you need to make sure that he's passing adequate urine, otherwise he'll have a nephrogenic shock also. So you put in a Foley's catheter into the bladder if necessary, if he can't pass the urine himself. These are the adequate medications that you need to ask the patient or the attendant that he's what he's taking, whether he's a diabetic, whether he's a hypertensive. These are the ABG, arterial blood gas analysis, that you need to do while you're doing a primary survey. And the last but not the least, if the patient is a female patient, please ask for history of pregnancy, because in case the patient is pregnant, we might not be able to do radiologic survey as we would want to. Secondary survey. Now, the principles of secondary survey, first of all, it is completed after the primary survey is completed and patient is adequately resuscitated. No patient with abnormal vital signs should proceed through a secondary survey. And in case you feel that you've gone wrong somewhere, you go back and you do the ABCD again. Secondary survey, we have a mnemonic for this: ample. Allergies, A for allergies. You ask for history of allergies, you ask for history of medications, you ask for any past medical history, pregnancy. And L is when the patient has had his last meal. E for any events around this at the scene of the injury or the environment. History can be gathered from the family members or the ambulance service or the first care providers. Once you know all this, you transfer to definitive care. And in case you see, all hospitals may not be as good as the tertiary care hospitals. So in case it's a smaller hospital, you need to decide whether the institution can handle the injuries that the patient has had, whether the comorbidities or patient with age extremes can be handled at that place. And further points to consider prior to transfer are whether the patient is stabilized enough, and in case he is, please don't delay uh, imaging. So now I'm going to start. I've probably given you an overview of what you have to do at the primary site. Now I'd just like to tell you some basics. It's like this is a normal chest X-ray. Are you all familiar with how to read a normal chest X-ray? Hello?
Some folks are.
Okay. In case you are not, like, just giving you an overview that the chest X-ray is comprised of bones, the mediastinum, and the lungs. And if you start reading, you have to start reading from the periphery. It contains the bones. This is the scapula, the clavicle, and the ribs. And you look for any rib injuries in this X-ray. I'm talking from the point of view of trauma. And when you come to the heart, you look for any enlargement. You look at the hilar. This is the hilum of the inner chest X-ray. Hilum comprises of the pulmonary artery. You look at the lung markings, whether lung markings are going peripherally or not, in case you see a collapsed lung anywhere, or you have two angles in a chest X-ray. This is called the CP angle. So one is the costophrenic angle and one is the cardiophrenic angle. So you have to look at both CP angles, because in case you have a hemothorax or any kind of pleural effusion, it will obstruct this angle. Okay. Then this is the diaphragm over here. This is a second diaphragm over here. This is an application of a CT scan. This is a normal rib cage. This is called a volume rendered technique that we can do nowadays in a multi-detector scanners. It's very fast and we get these scans within seconds. So in case we do suspect an injury to the chest or abdomen, we just push the patient into CT and do further examination. This is the X-ray of the cervical spine. You can see the curve of the cervical spine, and the cervical spine curve is called lordosis. What is the dorsal spine curve called? Can anybody answer?
Kyphosis.
Kyphosis, yeah, that's good. And what is the lumbar spine curve called? Can anybody say?
Scoliosis.
No, I wanted lordosis again. Scoliosis is a lateral curve. Lordosis is an extended curve. Okay. Lordosis is like this. Dorsal spine is like this. And lumbar spine is again like this. Okay. So in a spine X-ray, we see the anterior vertebral margin. This is the anterior vertebral line. This is the posterior vertebral line. And we have another line called the spinolaminar line, which all these three lines should not be disrupted. So after the vertebra to the spinolaminar line is the spinal cord and the spinal thecal sac in between this space. We go further. This is a pelvis X-ray. So we include both hips, and in case there are any fractures of these, we can see that. We include the sacrum over here. This is the eye leg wing. This is an abnormal pelvis X-ray. You can see that this joint at the pubic symphysis has been disrupted. And we could have many questions with this, but I think you're beginners and we'll leave you at that. But can anybody tell me what type of joint is a pubic symphysis? Or please tell me what type of joint is the hip joint?
Ball and socket
Ball
joint.
and socket.
Yeah, that's good. You got it. Ball and socket joint. Okay. What type of joint is the elbow joint?
Hinge joint.
Yeah, good. And what type of joint is the pubic symphysis?
Fibrocartilaginous.
No, there's another one. I want the typical name. Okay. Okay, this is disruption of that pubic symphysis. I'll tell you the name of the joint, but I want you to crack your brains. So I'm going to move further. This, as I said, like abdomen is not assessed by an X-ray. A fast examination, that is focused for assessment with sonography for trauma, has to be done, and it can detect any intra-abdominal, intracardiac fluid, and it's very fast. When you do it within 5 minutes, it's non-invasive, and it's very accurate. It's not expensive at all, and it can be repeated frequently, as many times as you want to do it. Sometimes when we have a very fat patient, we can't do it as accurately as we would like to, or in case there is air inside the soft tissues, then also the fast is not as accurate as in a thin patient. So indications, as actually we do fast for all trauma patients, but in case there is a equivocal abdominal sign, when there is hypotension and impaired mental status, and if there is any spinal cord injury, we'd like to do a fast first. So this is how we do it. We stand on the right of the patient, and this is a portable machine that we have, and we look at the perihepatic area, then the perisplenic area, and pelvis, and we turn the probe upwards towards the thorax, and we can see the pericardium. A fluid on sonography appears black, and anything black we don't like. Is called, this is the heart, and this thin stripe around it is the pericardial effusion. This would be blood in case of trauma. And see, this is the kidney. It's bean shaped, and this is the liver. And this black stripe in between. Can you tell me what space is between the liver and the kidney on the right? Liver and the right kidney.
Costal diaphragmatic recess.
No. That's the Morrison's pouch. Morrison's pouch is of great clinical importance. Whenever we suspect intra-abdominal injury, we look at this Morrison's pouch. This is the right kidney, this is the liver. In case I see fluid here, that means this is a dependent area of the abdomen, and that means some or the other abdominal injury has occurred. This is the pelvis. I see blood over here. So all these are indications of fast. I'm going to take you to some more x-rays. See, this is a patient I just had recently. His name is, I know what the name is. Okay, I'm not going to disclose the name. See, some of the ribs are not as good as, see, this. Can you see the fractures now? Are these visible?
Yes.
Yes.
Okay.
Yeah.
So this rib is completely good, but this is broken here. This is broken here. So this fellow has had multiple rib injuries. And see, I told you this is a costophrenic angle. This is a cardiophrenic angle. But can you see over here, both are not good. So this is a hemothorax that the patient had. This is CT. This is not simple. So when we saw so many rib injuries in that patient, I took him inside CT. I think it was at night 2 o'clock that I was called for this. And when we did a CT, I just kept deliberately this part of the scapula so that I can tell you that I've removed the scapula from the view, and I can punch out whatever I don't like. If I don't like the clavicle, I'm going to punch it out. So all these are post-processing techniques that are available to us. So after that, I found out that there are so many rib fractures, and when I turned the VRT image, I saw that there are flail segments also. Now that I told you what are flail segments, you know that these are independently fractured fragments that will move irrespective of whether the patient is inspiring or expiring, and it will cause injury to the underlying lung. So this is another picture of the pneumothorax. This is the collapsed lung. This is air inside the pleural cavity. This is a collapsed lung and air inside the space. So pictures of hemothorax again. So can you see this level here? It's not seen in a normal lung. Like this is a normal lung. This is all fluid inside the lung. Can you see this angle also? Some fluid here, but not as much as this. Even the size of this heart is not looking good. It's very big. See this hemothorax? All are pictures of hemothorax or probably any kind of pleural effusion. So tension pneumothorax is, see, this heart or the cardia is being pushed to the left, and the entire left hemithorax is filled with air. It is anyway filled with air, but the lung is occupying. The normal lung occupies with bronchovascular markings, but here there are no markings and there's only air. Look at this collapsed lung here and air compressing the lung. So what you need to do is put a needle here or a chest tube here so that it drains out all the air from here and this lung can again expand. I'm going to move to a CT head. CT head is the most important invention probably which the medical field has seen as far as diagnosis is concerned, be it headache or be it trauma. Especially trauma, CT is of undoubted importance. So this is a normal CT. This is how the brain looks like. Can you see these black things? These are ventricles and they contain fluid. There's CSF around the brain also, which cushions it. This is the bone around the brain. Is it clear? This is some calcification, and if you go deep into CT, you know where the normal calcifications are there. So this is a CT of an injured patient. Okay. And obviously this white, these white specks over here are not normal. If you see this bone has come inside and this is a depressed fracture, we have some scalp swelling around it, and this is a brain contusion. I'm going to go further in. So this is another brain CT and two shapes. This is biconvex, okay, probably like a rice dumpling. Okay, if you were an Indian, I would have said this is like an idli. Are there any Indians in the group?
Yes, ma'am.
Yep.
Yes.
Okay, so I think the idli is very familiar, or a rice dumpling. And when you see something like this, anything white in the CT is hemorrhage, except the bone, that is. So this is an extradural hematoma. Another kind of hemorrhage, but this is like a pancake. And in case you were an Indian, I would have said dosa. So I was taught in South India, so that's how I know the idli and dosa. but this is a subdural hemorrhage. Okay, and it could be old. When it's old, it looks black. When it's new, it looks white. This is just brain hemorrhage. After the blood, after a patient fell down, had trauma, after he had a hypertensive attack. You understand what I'm saying? He had a shooting blood pressure, then he fell down, and we realized that he's drowsy. We did a CT and we realized there is brain hemorrhage inside. So when we do CT, we know many more things. This is the CT of the same patient. You see it is fractured and moved inside, and this is called a depressed fracture. CT abdomen further revolutionized imaging in a way that it's difficult to state. So these are pictures of a patient who has had injury from my hospital. You can see the name. So these are pictures of, see, a lung contusion with hemothorax. This is a coronal view. This is the liver. This is the pancreas. These are two kidneys. And any injury to the liver, to the spleen, to the kidney, I can see without any effort. Obviously, for a radiologist, it's not much effort, but what I mean to say is that the diagnosis is really, really easy then. Okay, if I've not bored you enough, can we go towards some questions? Are you all up for it?
Yes,
Yeah.
definitely.
Yes, we're up.
Okay. So, as I said, I'm a radiologist. So, I'm going to show you something that I just taught you. Tell me what it is.
Head CT.
Yeah.
Dilated ventricles, most likely hydrocephalus.
Yeah.
Oh, okay. This is one ventricle. This is the other ventricle, and this is quite cheeked out. What I wanted to see is whether anybody could see the pancake or the dosa.
Subdural hematoma.
Subdural
Yeah, that's a
hematoma.
subdural. Good. Okay. So next, can you just tell me what investigation this is? What investigation this is?
MRI. So
Yeah,
for
it looks
coronal
like a bunch.
section.
So this is a MRI of the brain. It is so very beautiful to see such an MRI. See, these are the ventricles. This is the midline interhemispheric fissure. You can see this is the cortex of the brain. This is a white matter. And the paradox of the situation is that the white matter is really black and the gray matter is white. Can you make out? This is the gray matter. This is the white matter. That is the paradox. And this is a classical section of a brain where I can see the basal ganglia. Can somebody name the basal ganglia, please? Come on. Are you there with me?
The caudate.
Yeah, caudate. Yeah, this is a caudate. Good. Then the second one. The lentiform. The lentiform nucleus. Okay. This is the lentiform nucleus. This is the thalamus. Okay. This is the thalamus. And something which is V-shaped and it goes in between all these structures. It is V-shaped. It is a bundle of white matter. And it goes in between the caudate, lentiform and the thalamus. Can somebody tell me? That's the
Putamen.
internal capsule. Okay.
Yes.
The frontal, the anterior-most are the frontals. On the sides are the lateral temporal lobes, and posteriorly We have the occipital lobes. There's one more, no? What is this? Parietal lobe. Okay. This is another head CT. Can somebody tell me what this is?
Subdural hematoma,
Yeah,
probably.
that's not subdural. Okay. This is a chest CT, and I'm going to tell you because I've not really made it clear. These are hemothorax on both sides. This is a section of the posterior fossa. Can somebody tell me the structures in the posterior fossa? This should be the cerebellum. This should be the pons, okay? And in case I told you that there is an internal acoustic meatus, does it ring a bell? There are two nerves which go through the internal acoustic meatus. What are the two nerves?
Vestibulocochlear nerve.
Yeah, and?
Facial nerve.
Yeah, good, very good. So this section I already showed you. I told you there's a hemothorax. I told you this is the spleen. I told you this is the liver. These are the kidneys. Tell me what this is.
This is the aorta.
Yeah, good. That's aorta. So this is an abdomen CT. This is a liver, kidneys, pancreas, kidney. What is this?
Duodenum.
Huh? Duodenum. Okay, I'm telling you this is the duodenum. Okay. Tell me what is this?
Gallbladder.
Yeah, very good. Gallbladder. Okay. This is a sagittal section of the brain. Okay. Like you see it in all your anatomy manuals. So this is the occipital lobe, parietal lobe, frontal lobe. And there is something which connects the two hemispheres of the brain. It's a bundle of white matter.
Corpus callosum.
Yeah, good, very good. And then I have a brain stem, and this is the cervical spinal cord. Okay. So brain stem, what are the parts of the brain stem? We'll start from the top. Tell me.
Diencephalon.
Okay. What do you call the diencephalon?
We have the pons, the midbrain, and the medulla.
Okay,
And
this is
medulla
the
oblongata.
pons. This is the medulla. And there's another one. What is on top? Midbrain. Okay, midbrain. And just in relation to the brain stem, what are these?
Cerebellum.
Yeah, that is the cerebellum. Between the uh, brainstem and the cerebellum, there is another structure. This, can you tell me what that is? It's full of CSF.
That's the fourth ventricle?
Yeah, good. Who's that? Whoever is that is my darling. Okay, and I have another structure to tell you. This is the pituitary gland. Okay, and I'm not going to torture you more with this. I'm going to go further and tell you that this is the entire view of the entire spine of a man. Okay, how good MRI is, see, what I meant is this is a cervical lordosis. This is the thoracic kyphosis. Again, the spine down below takes another turn and is called the lumbar lordosis. Here what has happened is the straightening of the spine. So these in between these are vertebra, okay? These are the 7 cervical vertebra, then the 12 dorsal. And how many lumbar? How many lumbar?
Five.
Yeah, great. Lumbar. And how many sacral?
Those are fused generally.
And how many coccygeal?
2 to 3.
1.
No, coccygeal, 2-3 coccygeal pieces, yes. Okay, so in between the vertebra are the?
Intervertebral discs.
Yes, great. So the intervertebral disc, you can see some of them have become black. Those are dehydrated, okay? These are dehydrated discs. And can you tell me the parts of an intervertebral disc? Or is it too much?
Nucleus pulposus.
Yes, that is black.
And
Okay.
fibrous annulus.
Yeah, the fibrous annulus. Great. So I'm going to finish my trauma over here with telling you that there's only one safe way, and there is only one ABCD approach to trauma. And when you find a problem, please fix it. And after anything that you do, please reassess. Okay. I have another presentation to go. If you're feeling up to it, I can continue. Or I can fix another time for you for this. What do you say?
We can go on.
We can continue.
Okay.
Yeah, we would
We can
like
go
to
on.
hear
This is
about.
a smaller one. This is COVID. So as we all are going through COVID, and because if it was not for COVID, I would not be presenting to you right now. You would have had a teacher teach you in person. So this is something that we do at our hospital. When COVID struck us last year, we were overwhelmed by what to do, how to do, how we would face a patient. Until we faced the patient for the first time, we never knew how it would be. But since then, hundreds have come and hundreds have healed, hundreds have gone also. But it is in our experience, and it's a continuous learning one for us, all of us, what's going on. It's not very happy everything, but we are still learning. So what I named the Devi protocol is something that is still going on, and every day is a new learning experience. This is my hospital, and this is where we come from, the state of Jammu and Kashmir in India. So when the contagion hit us last year, we found out that there was a new name, what we call the coronavirus or the SARS-CoV-2, was discovered in Wuhan, China in 2019, December. And we had no information how it would spread. And but the news that we all got was so scary that life changed in the last 2 years in a way that we would not have thought. What we really want to highlight is that the minimum standard precautions be taken: a double face mask, eye protection, goggles, a head hood, a apron which is water resistant, then leggings, gloves, and a head covering. And in the end, you look like an astronaut. But people were told to stay at home, not to come out. But still the virus spread. And the word positive means such a scary thing that hospitals became forbidden zones, and the home was considered the blessed paradise. How it is going to change us, we're still learning. And you're in a country fortunate enough to have conquered some part of it, although you never know what is coming in future for you. So many new variants which are striking everywhere that it may be very difficult to control. So when a patient comes to your accident and emergency, a medical officer and a trained nurse receives them. And as soon as they tell us a history of something like uh, breathlessness, we get activated and we order a chest x-ray, and we take a pulse oximeter and see their saturations. In case we see a normal chest x-ray, we would like further confirmation whether the patient has COVID or not, and we would ask for a test. And in case we see something abnormal on the chest x-ray, we say that okay, this patient could be COVID. One minute.
टीम्स
Yeah.
टीम्स पे जाओ ना, पहले शेयर करो, वो नहीं कर रहे तू
क्यों? Is it audible now?
Yes, we can hear you.
Yes, we can.
Okay, I'm very sorry. I think I had gone through so many slides also, not realizing that I had not set the settings. So, when COVID came 2 years back, um we had not realized what it would do to us and how overwhelming it would be. Um, uh, People who have gone to the hospital will realize what all implications it has had, how we've had to change our mannerisms, how doctors have had to change their behavior with the patients, and how it has taken a toll on us through this time. So this is our hospital. We live in the state of Jammu and Kashmir in India, and uh, it's a small hospital, 500 beds. Uh, but COVID has still managed to hit us badly. So in 2019 December, when COVID came to China, however it came, it doesn't matter now that it has hit all the countries in a manner that we would never have imagined before. We found out that it was caused by a contagion which was so fast beyond what we would have thought. previous to this, the Ebola virus, the SARS, all were falling short of what COVID has done to us. And now, when we receive a patient in our ER, first of all, we have to evaluate whether the patient has COVID or is he another generalized patient like a heart patient or a gastro patient. So the spread is so fast, and with the new variants coming in, which are more virulent and faster than the older ones. So the minimum standard precautions that we had to take was a double face mask, at least a double face mask with sealing of the nose so that we don't blur our uh, specs and our eyewear, and then eye protection with goggles and a head hood, and we wear an apron or a water resistant protective equipment. Then we wear leggings, and we wear gloves and double gloves and a head covering on top of the entire thing and a face shield to top it all. So previously people enjoyed going out. After COVID came, we realized that the home was the sweetest place and the blessed paradise. And going to work for so many also was not possible, except doctors. I don't think many people went to work during the entire thing. To get a positive report, it was so overwhelming. The scare of the hospital was so terrifying that patients would stay at home and try to manage on a community level till they would fall so sick to come to the hospital. What lies in future, I don't know, but we are hoping that we can change things in a better way. So once the patient comes to us in the accident and emergency, there's a screening medical officer or a trained nurse who receives and gives primary care to the patient. We make sure that no patient is devoid of that, at least, so that be it a patient who is having gastritis, but he may also have COVID, but at least he should get primary medical attention from all the doctors and the nurses available. So in case the patient says that there is breathlessness, you do a chest x-ray and you feel it is normal, you could still send the blood work or a nasal swab or a pharyngeal swab. And we have altered this protocol. I'm going to put in so many things now. In case you get an abnormal chest x-ray, first of all, isolate the patient and make them go for a PCR. And then abnormal chest x-ray could also include many other things that are cold pathologies compared to COVID. And in case you get a pneumonia, you order a CT scan. So what I'm trying to stress here is that even though it's a very difficult time, we have not stopped working. Doctors have evolved, and someday we are going to come on top of this virus. So protocol for doing chest x-rays also as a triage when we started, because we could not do CTs for everybody. The RT-PCR facilities all over, even I think in your country, it takes time for the results to come. So till that time, we started doing chest x-rays so that we could get some information from the patient and try to isolate them before they could spread it to the rest of the community. So even for doing a chest x-ray in a COVID patient, you had to take so many precautions. We had to cover the machines, we had to cover the cassettes that we do, then we had to wear PPEs and N95 masks. And the world changed so drastically that I don't know, we have made so many protocols in the last 1 year that we have not done in so many years. So I'm going to show you some X-rays that I see so overwhelming now that I've shown you a normal chest X-ray. See, a COVID X-ray shows peripheral opacity. Can you see this? It's not central, it's peripheral. Over here also peripheral. It's more on the sides than in the centers. And it could be more, but it is more towards the periphery. That's how we recognize a COVID pneumonia. And as COVID progressed, the X-rays became worse and worse. So phase 1 was when we did only X-rays. Then we included CT. And after we got the rapid kits, they were the antigen kits that would give us the result in 15 minutes. So we, though they are not as accurate as the RT-PCR results, but at least we could isolate the very, very high viral load and highly infectious patients from the least ones. So we started doing a rapid test first. And in case he was positive, we would take him to the COVID ward. And in case he was negative, we would still do a PCR and plan a CT. And in case CT was positive for COVID, we would keep a patient in an orange zone. We created zones, which were called green zone, orange zone, red zone. So orange was the place where we would keep the suspected patients. And CT protocol, we did a non-contrast CT, low radiation dose because we had to do so many CTs. We made sure that the younger patients got a low radiation dose protocol, low kV settings. These are voltage settings. Once you become a radiologist, you know kV and MA as your brother and sister. And then we saw many patterns which we had never seen before, and it has been a learning experience. I think this is beyond the scope of this talk, but okay, ground glass is what we are seeing everywhere. The involvement is bilateral, ground glass opacification, and multilobar involvement can be present, and a more peripheral distribution. So some things are intermediate, like we could have this, we could not have it. You need not know all that. Again, in a chest CT, we saw more of ground glass, crazy paving. Crazy paving would indicate ARDS picture. ARDS is acute respiratory distress syndrome. And bronchiectasis, those who are familiar with the term, because of the fibrosis that was occurring, there would be more traction and it caused so much architectural distortion in the lungs. It would cause a lot of bronchiectasis, some subpleural bands. And we started scoring these patients. It has become so bad that every night our COVID protocol starts. And we start doing CTs for COVID patients at night, even the OPDs and the inpatients. Everybody is done at night. Then we clean the department and again reopen in the morning for the normal patients. So our world has changed. We have night technicians and day technicians. In early stage, we see a small GGO. In the GGO is ground glass opacity. In the progressive, we see extensive ground glass, and then the peak stage is when the consolidation of pneumonia occurs. And then absorption stage is when the fibrosis occurs. So these are early stages. This is all ground glass opacity, typical on the outside of the lung, not on the inside. All these wedge-shaped ground glass opacities. Then they increase. This is called the progressive phase. And then they resolve by fibrosis. These are the luckier patients who make it. Those who don't make it become really bad. The entire lung is involved and we get an ARDS picture. These are the progressive phases. of these patients. So these are the bronchi being dilated, so much architectural distortion is called bronchiectasis. Okay, the black bronchus sign. This is another sign called the Petresi paving. Even when you do medicine, you will have to learn all these. We developed more science and we realized that the vessels were becoming dilated in those places where the involvement was more, and we proposed the theory of vasculitis. Because of this vasculitis, we were getting more emboli and more of myocardial infarctions, more of infarctions in all these cases. We started seeing halo signs, more of fungi inside these areas after the use of corticosteroids. And some people healed and resolved. These are the post-COVID pictures after these pictures, okay? And some people did not, and we lost these people. But we're still optimistic that we'll make it. And if we were not, it would not have, this journey would not have continued so far. So thank you everybody for listening to me today. And I hope you've understood some part of it, whatever I've tried to tell you across. And there is still hope. Everybody gets vaccinated, we develop a herd immunity, and we get through this. Thank you so much, everybody.
Thank you so much, doctor.
Thank you so
Thank you so much.
Thank you.
Okay, bye-bye.
Thank you, doctor.
Okay, bye-bye.
Thank you so much, doctor. Have a nice day.
Yeah, see you sometime else.
We really appreciated your presentations. And thank you everyone for joining as well.
Okay.
Stay safe. Bye-bye.